Hi, I'm Dr. Steve Andriese. I'm a physical medicine rehab specialist with Neuromuscular and Rehab Associates of Northern Michigan. And I, along with Northern Physician Organization, have developed a low back pain protocol. This is meant to help primary care providers in assisting in management of people with low back pain and lower extremity radiculopathy. So I'm going to take you through the protocol now, if you refer to what you have there on your screen. The two basic starting points: low back pain, and all the pain is axial in the low back, and then the other radiculopathy being pain going down the legs, one or both, and with or without low back pain. Recognize at any time that you have a patient, low back pain or radiculopathy, don't hesitate to send that patient to a physical medicine and rehab specialist. We happily take them. They don't have to have been worked up first. They don't need imaging. Anytime, I'm happy to see them. But just to help guide you a bit, let's talk through some of the worrisome initial things that you're screening for. Under low back pain, the three main things that you would be worried about that are red flags that might suggest an immediate surgical referral would be infection, tumor, or fracture. Regarding radiculopathy, three red flags would be progressive weakness. They're just getting weaker and weaker, a foot drop that's getting weaker. Intractable pain, they're in so much pain they can't get out of bed, they need an ambulance to take them to the hospital. Cauda equina syndrome, basically saddle anesthesia, inability to urinate, which if they have overflow voiding with inability to urinate, urinary incontinence can be part of that, along with lower extremity pain or weakness. So those represent 6 absolute indications for surgery: intractable pain, progressive weakness, Cauda equina syndrome, tumor, fracture, or infection. Apart from those, there's no need for you to get a surgical consultation. Those are the things that the surgeon needs to be seeing right off the bat, but without that, you have the options of proceeding with conservative management. Now, when you're contemplating imaging, if any of those are a concern to you, imaging is appropriate, and blood tests may be indicated as well. But recognize that MRI imaging, it almost never helps when it comes to low back pain. In fact, there's articles written saying MRI imaging for low back pain is worse than worthless because it basically leads people astray. With radiculopathy, I don't need it to initiate treatment of a radiculopathy, but everybody has to do what they're comfortable with. So just so you're aware of when MRI is indicated or when it's not, and if you're not clear on that, feel free to ask me anytime. I'm happy to talk to you about that. So assuming that we've ruled out all the red flags and you're down to this blue diamond-shaped square saying if negative, we're going to proceed with conservative management, I'd like to just speak generally about conservative management a minute. The 3 pillars of conservative management that I talk to my patients about are, number 1, getting at the root cause of the problem, which is the realm of the physical therapy and physical therapists and exercise. 2, changing the things in their lives that are aggravating their pain, modifying their activity. If they keep re-irritating, it's going to be very hard to get them better. And 3, additional treatments. And additional treatments, I consider things like injections and manipulation and medications and so on. And we'll talk about that. And just to take one more step back, it does help to consider some of the pathophysiology of back pain when applying these concepts. If, in simplest terms, there's 3 main structures that cause pain in the low back. The discs themselves can get tears. They all do get tears, but when they get out into the annulus, certain areas where there's sensation, that's back pain. The facet joints cause back pain, and SI joints. Radiculopathy is when nerves are irritated, either by the disc, associated with stenosis, associated with inflammation. So, in simplest terms, whatever's causing low back pain is primarily a function of stress or pressure through the lumbar spine. So I tell my patients, in simplest terms, to get at the root cause of the problem, we want to unstress or de-stress, reduce pressure on the lumbar spine. So that is where physical therapy and exercise comes in. Okay, so I'll get back to that in a minute. But if, as the primary care doctor, you're just initially seeing somebody with back pain, it's benign, you just want to initiate some treatment, we've gone through a number of things you could try initially. Different medications listed there, anti-inflammatories, anti-spasticity medications, muscle relaxants. Anti-inflammatory diet is excellent to suggest to people. Turmeric, cherry juice, ground up flaxseed, calcium, magnesium, zinc, and vitamin D help with muscle spasms and Charlie horses. That's part of it sometimes. One of the treatments that I've mentioned already, manipulation, is generally felt to be most effective in the first 16 days. All therapists nowadays are trained in it. Osteopathic specialists that do additional training in manipulation will have those skills and available to people, and chiropractors. Of course, smoking cessation makes sense for everybody, but especially back pain patients because of the small vasculature to the disc that gets further constricted with nicotine. And again, here's where you really want to start talking to them about educating them about the importance of exercise. And I'm not talking general exercise. I'm talking, again, now I'm going to get back to that root cause of the problem. If we want to take stress off the lumbar spine, we want to build up the support for that spine. And the support for the spine comes from not just core muscles, but pelvic floor, hips, legs, even upper postural muscles. Because in essence, two components of reducing stress on the lumbar spine, one is stretching key muscles that are pulling across the painful structures, and the other is developing regular strength to those muscles. And when you're educating them, you have to make it clear that any effective exercise program has to be something that becomes part of their lifestyle. Because if they're thinking they're going to go through 6 weeks of PT and that's the end of it, they're likely not going to be continuing to support their spine and the painful structures over the long term. So we've described here how there's some things you can try initially. I would have a low threshold for referring to physical therapy. If you're considering your second dose pack, for instance, I would be referring to a physical therapist at that point to, again, try to get at the root cause of the problem. The physical therapist's approach really is one of specialized exercise for this particular patient. In the process of defining that and developing that, they are assessing their ability to improve the situation, and they may utilize these categories of acute versus subacute versus chronic pain in determining how many visits it requires them to get to the point where they can give feedback to you. We've developed a form that's a little simpler than the CMS forms that you're used to receiving from physical therapists. This form comes from physical therapy and will probably give you suggestions as to where the patient is in their progress and what might else be needed. So, again, if the patient's getting better right away, that makes it easy. They're discharged to a home exercise program. If they're making slow progress, they might need more therapy visits, ultimately to graduate to a home exercise program. And if they're not progressing, that's when they may need a referral to a physiatrist or a pain specialist. And the bottom rectangular blue box refers to things that we'll do, further evaluation. We may do some additional diagnostic testing or imaging if it's indicated. The interventional pain procedures that we use are best used to facilitate progress in therapy or facilitate progress with their exercise program. And there may be additional interventions that we're suggesting: pain psychology, additional physical therapy, other providers that may be of assistance. So hopefully that helps.